Hello guys, we'll start now.
Hello, sir.
Okay, we'll do two topics today. First is TMJ, and the next one would be vestibular system. Okay, first is TMJ. Now we'll quickly start with anatomy. So TMJ is a synovial, condylar, modified ovoid, and hinge type joint with fibrocartilaginous surface rather than hyaline cartilage and an articular disc. This disc completely divides each joint into two cavities. So this is the disc. This up, upper would be above disc would be upper cavity, and lower part of disc would be the lower cavity. So this is the TMJ, right? We can put our finger inside our ear, and if we open our mouth, close and open our mouth, we can feel the movement of the TMJ. This is very important. From exam point of view, one question is almost sure regarding resting position, closed back position, open back position. Okay, read it from Maggie, each and every joint. So what is the resting position of TMJ? Mouth slightly open, lips together, teeth not in contact. So lips are closed, but teeth are not touching each other. That is the resting position of TMJ. What is the closed back position? Teeth tightly clenched. Capsular pattern is limiting of mouth opening. Now, when it comes to muscle action, here we need to know, okay, which muscles open the mouth, which muscles closes it, protrusion, retraction, lateral deviation. So I went to Tim Hortons, but it was closed. So closing is by Tim. T is temporalis, I is internal pterygoid or medial pterygoid, M is masseter. Three muscles are there which are involved in closing of mouth. Opening, when it comes to opening, bilateral lateral pterygoid. Okay, so while opening, lateral pterygoid of both sides, right and left sides, are working. Okay, digastric, genohyoid, myohyoid. So we can imagine, right, how hyoid bone is in the anterior part of the neck. So if these muscles will contract, mouth will automatically open. Right? That is hyoids. Two hyoids, digastric and lateral pterygoid. Bilateral side. That is opening. Lateral deviation. Okay, all of you do it so that you can remember. Can you laterally deviate your mandible towards your right? If you are doing along with me, okay, so if you are deviating your mandible towards your right side, so your right side lateral pterygoid is working. Okay, right side lateral pterygoid plus left side medial pterygoid is working. Do it, guys. In exam, they can ask muscle function because it is confusing. So if you are laterally deviating towards the right side, your right lateral pterygoid is working and left side medial pterygoid is working. Okay, see, you can see it here. So lateral deviation of mandible by lateral pterygoid of ipsilateral and medial pterygoid of contralateral plus temporalis massetus. Okay, protrusion is bilateral, lateral and medial pterygoid. So do it, protrude your mandible forward. So both pterygoids, both sides, median and lateral pterygoids are working to protrude. Masseter, temporalis anterior fibers, hyoid, digastric. This is the table from Dutton. Read it. I'll send this PDF as well. Now, when it comes to biomechanics, TMJ has 3 degrees of freedom, which means it moves in 3 planes: sagittal, horizontal, and frontal. Okay, so what are 3 movements? Rotation, gliding or translation. Third is protrusion and retrusion. When it comes to rotation, okay, rotation, it occurs in the lower cavity. That means below the disc. Gliding or translation occurs in the upper cavity of the joint. Rotation happens first. Okay. So when we are opening our mouth, what happens first? Rotation happens, which is happening in the lower cavity of the joint. So in TMJ, remember like this, in temporomandibular joint, right? It is temporomandibular joint. So which one is mobile? Temporal or mandible? Mandible is mobile, right? So the lower cavity one will move. This is mandible, right? This is the disc, and uh, this is the temporal bone. So basically, oh, just a minute, someone wants to join the class. Okay. So mandible is the fixed one, right? And this guy is moving. So the lower cavity is moving first, right? So it is the rotation. Rotation happens first because we know rotation happens in the lower cavity of the joint. So first rotation happens while opening the mouth, okay, followed by gliding or translation. Gliding translation happens next and allows the jaw to open fully. This is enough. This much biomechanics information should be sufficient. Which happens first? Okay, rotation happens first in the lower cavity, followed by gliding or translation. Then, okay, range of motion. This is also an important concept. So, what is the normal range of motion? Functional opening. Yes, Ishan.
Sir, I just wanted to ask in what direction is the glide in mouth opening?
It is a concave convex, right? So, it happens. Which one is moving? Concave is moving, right? So, glide, and if concave is moving on convex, what happens? What is the rule?
Same direction.
Same direction. Same rule. Okay, whenever there is a joint and the same principle, we will apply the same principle if it is concave convex joint. Okay, whichever joint is moving. So if it is convex moving on concave, then it is opposite. Otherwise, it is in the same direction. So normal range of motion, functional opening is 25 to 35 millimeter. Okay, what is functional? That means normal functioning. So eating, speaking, these activities requires 25 to 35 millimeter of opening. Maximum opening of mouth is 40 to 50 millimeter. Okay, that is end range stretch of periarticular tissues. That is the maximum. Functional range is 2 to 3 knuckles. Okay, excessive opening more than 3 knuckles, which suggests hypermobility. Okay, normal opening of mouth is 3 fingers. There's a test as well, 3 knuckle test. If you have opened Maggie, that picture is there. Now, while opening mouth, which side jaw deviates? Hypomobile side or hypermobile side, guys? Okay, let's say this is jaw. Okay, you are looking from frontal plane. Okay, so if let's say right side temporomandibular joint is hypomobile, so and now the person is opening the mouth, which side jaw will deviate towards the hypomobile side or hypermobile side? Right is hypo here.
Hypomobile.
Hypo or hyper?
Hypo.
Hypo.
Hypo, right? It is because hypomobile is the tight, right? Whichever side is tight, the jaw will deviate towards the same side. Same rule applies in case of facial palsy, Bell's palsy, isn't it? So if right side is weak, face will deviate towards the strongest side. So jaw deviates towards towards one side while opening the mouth. That means that side is hypomobile or restricted. The condyle on the restricted side cannot glide forward properly. So mandible swings towards that side. Okay. So in hypermobile side, jaw will go away from that side. Just opposite. If you remember this concept, definitely if jaw is moving towards the hypermobile side, jaw will go away from the hypermobile side. Okay, the condyle on hypermobile side moves excessively forward compared to other side. Now, what are the causes of limited mouth opening? There could be muscles could be tight, could be a problem in a joint or other things. Let's see. Muscle causes. So chronic contraction, acute spasm, trismus. Myofascial trigger points in masseter, temporalis or medial pterygoid. TIM. Tim. If Tim are tight, Tim Horton was closed, right? Okay. So these, if the muscles which are closing the mouth are tight, they will definitely limit opening. What are the joints cause? Ankylosis, disc displacement without reduction, could be osteoarthritis as well. So measurement clues are 10 to 20 mm, possible muscle contraction or ankylosis. This is not that important, guys. Okay, it is in Maggie. Painful limited with recent onset. Consider acute disc displacement without reduction. We will read about this. Okay, disc displacement without reduction, with reduction. These are important concepts. Now, normal movement and clicking. Normally, the condyles, jawbone slides smoothly along disc during mouth opening and closing. When the disc or condyles move abnormally, a clicking or popping sound can occur. Now, during opening, disc initially displaced, condyles slip over it, opening click. During closing, disc slips back anteriorly, closing click. This will be clear, guys, in coming slides. Okay. Yes, Anshuman.
What is sliding of disc anteriorly while closing?
We will discuss about it in this slide. So before going to this slide, as you have asked, this is the condyle, right? Okay, this condyle is rotation. Rotation component is happening in the lower compartment, right? We read that is the first movement. So the condyle moves over the disc. This is the disc. Okay, this is temporal bone, right? This is the temporal bone. Mandible is down, and this is the disc. So this picture is actually functional dislocation of disc. Now, as you can see here, the disc has been dislocated anteriorly, like in low back or in cervical, in our spine, the disc is displaced towards the back side, isn't it? PIVD. Posterior intervertebral disc bulge happens, right? Here also the condition is there where the disc is bulged anteriorly. Okay, see now. Now this, ideally, disc should have been in this position. Now the disc has moved anteriorly compared to condyle, isn't it? Just see it. Now if the disc is here, now if the condyle has to move, now condyle will start rotating, right? The rotation component while opening the mouth. Now this condyle has to jump at the middle of the disc, isn't it? Actually, this middle of the disc was supposed to be here, exactly at the center of the condyle, isn't it? It is now dislocated anteriorly. Now, if the shoulder is dislocated, and if we put that shoulder in its original place, what do we say? What is that term?
Reduction.
Pop or reduction.
Reduction, right? So this reduction word is there. So now what we will say is, if while opening the mouth, if this condyle goes and sets, because this condyle will translate anteriorly if the person opens the mouth, right? And it will slide and sit at the middle of the disc. Okay, that at that time we will call it as reduction. Okay, but what happens is, in this condition, while condyle jumps at the center of the disc, then we will hear one sound, that is click, isn't it? See, this is the bulged part, and the condyle has to move through this bigger portion, then it comes at this center portion, so there will be one click, okay, while going up here, and one click while going out. Again, if while closing the mouth the condyle will move back, right, then there will be one more click. So if you understood what I just said, now let's see what are the condition if there's a disc displacement. Okay, now the disc usually the disc is displaced anteriorly. Okay, now the first condition is disc displacement with reduction. Now disc moves out of its position. Disc displacement, usually anteriorly, but returns to normal during movement. Okay, what happens if the person suffers from this condition, disc displacement with reduction? What will be the symptoms? So as I said, now disc is lying anteriorly to the condyle. It has to jump. While opening the mouth, it will jump and reduce at the center. It will come at the center of the disc. We will hear one click. Okay, the condyle will remain at the center. Maybe both of them will slide anteriorly according to how much the mouth is going to open, right? And when the person closes the mouth, the condyle will jump off the disc, and one more click will be heard while closing the mouth. We will call that as reciprocal clicking. Okay, one click during opening and another click while closing. Okay, so in exam, if they ask, the person comes to you and complains of clicking while opening the mouth and another click while closing the mouth, which condition he is suffering from? He's having disc displacement with reduction. Reduction is happening, right? The condyle is sitting exactly at the center of the disc where it is supposed to. That is reduction. After dislocation of the shoulder, we are relocating and calling it as reduction. So we are calling it as reduction because the condyle is sitting at the center of the disc, which is displaced anteriorly. Okay, now jaw movement pattern effect. Jaw deviates towards affected side on opening, then straightens, normal or near normal range of motion. Yes, Anshuman.
So when closing the mouth, will the disc will go back and the head of
No, the disc won't go back. Disc is displaced anteriorly. The condyle will jump off the disc, right? Then we will hear click. If the disc moves along with the condyle, we won't hear the click. One click, we will hear one click when this condyle is jumping from this posterior portion of the disc, isn't it? and it
Yes.
gets reduced at the center, and it has to jump off that bump. Then we'll hear click.
The second click.
Second click, yes.
Okay.
Now, second condition is disk displacement without reduction. Now, from name, we'll come to know disk has been displaced, but while opening the mouth, there's no reduction. It means the condyle is not sitting at the center of the disk, right? So the disk remain displaced throughout the movement and does not reduce. That means the condyle is not going anteriorly enough to sit on that disk, right? If condyle doesn't jump off, okay, if the condyle doesn't jump off at the center of the disk, will we hear click? Yes or no, guys? Will there be a click or
No.
not? No, no, because that click was because the condyle was, this crossing this bump, isn't it? Then sitting at the center. So this friction or whatever was producing the sound, click. So here, as the name says, disk displacement without reduction. So the condyle did not sit at the center of the disk, right? Disk is displaced, disk is at the anterior side, right? But the thing is, condyle is not moving through the posterior part of the disc and sitting at the center. So no click. May have dull pain or catching feeling. Okay, just give me a second, guys. Sorry, guys. Today, yeah, I'm at different place today. So yes. So here, disk is at the anterior side. Okay, disk has moved out of its position. Same thing, usually anteriorly. Okay, same thing, but the condyle is not jumping off the disc and sitting at the center. Instead, consider that condyle is compressing the disc more anteriorly. Think like that. Okay, so there won't be no click, there will be dull pain. Okay, so what will happen? Definitely limited mouth opening, deviation towards the affected side. This is also known as closed lock. Yes, Ishan, you have raised hand.
Sir, the disc displacement without reduction, in
Mhm.
that you are saying that the condyle, the disc will not reduce back. So in this
No, no,
photo,
no.
like this is what it seems to be, right?
Don't look at this
Like
photos and
because
all. See, imagine this picture. Okay,
right.
these are the different stages of. I'm just using the reference of this picture so that you guys will understand. Okay, imagine this is the disc. Okay, this is the disc. Okay, which is already bulged or displaced anteriorly, right? Now the person starts opening the mouth, and instead of condyle jumping off the disc and getting reduced, it is further compressing the disc. Got it? Click will come if the condyle jump off the posterior part of the disc and get reduced at the center. Reduction means shoulder should remain inside the glenoid fossa, right? Similarly here, condyle should sit at the center of the disc. This is the shape of the disc. Got it? So instead of
Yeah, sir.
jumping off the posterior respective disc and sitting, now the condyle is further compressing the disc, which is already lying anteriorly. And the name says disc displacement is there anteriorly, but without reduction. Without reduction means the condyle is remaining posterior to the disc. That means no clicking. No clicking means limited mouth opening because the condyle has to rotate, translate anteriorly. Both, right? Rotation is happening at the lower chamber, translation is happening at the upper chamber, right? So this is known as closed lock. Closed lock means the mouth is closed and is locked, right? Third is now disc displacement with subluxation. Okay. Now condyle and disc moves excessively forward, sometimes beyond articular eminence. So two clicks, one on opening, one or closing. What will happen is this is condyle. Okay. This is disc. Right. Okay. This is condyle. As we are saying, disc is anteriorly displaced. Okay. We will call it reduced if the condyle comes and sits over this place. Got it? Right? So, if the condyle crosses this bump, we will hear one click. That is clear. It sits over this place, right? But if the person continues to open mouth, okay, pathology, we are talking about some pathology, right? So the condyle will cross this bump as well, right, while opening the mouth, and the condyle will reach here. You guys got it? So this condyle was here initially. One click was while moving through this bump, and the condyle keeps on going anteriorly, and one click will be heard when it passes this bump. Okay, so disc displacement with subluxation, that is subluxation, two clicks. So condyle and disc moves excessively forward, right? So there will be two clicks. This is wrong, guys. Okay, forget it. There will be two clicks on opening and two clicks while closing. Okay, it is in Maggie. Don't go with these words. Okay, so there will be two clicks while opening and two clicks while closing the mouth. Okay, jaw may get temporarily stuck, open lock, and may need manual assistance to close it, seen in hypermobile joints. Which glide will you give, guys, to close the mouth?
Posterior.
Okay, posterior. We'll come to that later. Okay, so disc displacement with subluxation, there will be 2 clicks while opening and 2 clicks while closing. 2 clicks while opening, we got it right because it has reached here. Now when coming back, when the person will start closing mouth, this condyle has to jump off this bump, and 1 click when it reaches here reduces, right? It will continue to come back and it has to jump across this bump where the condyle will remain here and the disc is displaced as the name says. So there will be disc displacement with subluxation. There will be 2 clicks while opening and 2 clicks while closing. Yes, Anshuman.
Why open lock? Because we are listening 2 clicks again, so it is getting back to its original position. Then why we are saying open lock?
Jaw may get temporarily stuck open. If it remains stuck open, then we'll call it as open lock. Mouth remains open. Here the mouth was remaining closed. That's why we were saying it as closed lock. Here the mouth is remaining open. That's why we're calling it open lock. If it is stuck in open position.
So if it is stuck in open position, then we will just hear 2 clicks, right? When opening, because it's not closing.
If it remains open, we'll call it as open lock. Okay.
And we'll just hear 2 clicks.
Yeah, there will be 2 clicks and mouth will remain open.
Okay.
But if they ask you about disc displacement with subluxation, what will happen? You have to explain the whole thing. You have to say there will be 2 clicks while opening the mouth and 2 clicks while closing the mouth. Okay.
Okay.
Next is dull or soft click caused by ligament movement, mild adhesion, release, or muscle incoordination. Soft or low intensity click, not painful or pathological. Okay. Normal or slightly altered motion may occur after prolonged clenching. So same concept here, closed lock, open lock. So closed lock occurs with disc displacement without reduction. Okay. Disc blocks condylar translation. No click, jaw will deviate towards the affected side. We have read it, right? Open lock means occurs when condyle translates too far forward and cannot return to the fossa. Okay. Jaw stuck open may hear 2 clicks on opening, 2 on closing. True dislocation, mouth cannot close without manual reduction. If it remains open, then only we will call it as open lock. If it is coming back and closing, we will call it as disc displacement with subluxation. Clear, guys? So there are many pictures in Maggie. If you want to see, you can see it, but if you have understood this much, no need to break your head. So there are stages of disc dysfunction. Stage 1, 2, 3, 4. First is disc slightly anterior and medial on mandibular condyle. We just read, right? Disc bulge happens mostly at the anterior and medial on mandibular condyle. There is inconsistent click. Definitely at stage 1 there will be inconsistent click. May or may not be present. Mild or no pain. Okay, in stage 1 you consider disc bulge of low back, right? If disc herniation, basically, if that is stage 1, person will have mild or no pain, right? Inconsistent pain. Here we are talking about click, so the click is inconsistent. There is mild or no pain, right? So in stage 2 the herniation will increase. The disc will move more anteriorly, right? Anterior and medial. Now if it goes slightly anterior, right, then definitely there will be reciprocal click. The condyle will jump off the edge, posterior edge, and there will be reciprocal click while closing the mouth. Now, early on opening, late on closing. This I'll describe later because similar term is coming down. Okay. Now, severe consistent pain. Okay, because it is getting rubbed, right? There's a friction going on between condyle and the disc, posterior portion of the disc every time. So there will be severe consistent pain. The pain was not consistent in stage 1. Now the pain is becoming consistent at stage 2. Now in stage 3, reciprocal consistent click present. Now later on opening, earlier on closing. This is the most painful stage. Okay. This is condyle. This is the disc. This is stage 2. Now in stage 3, this is the condyle, right? And the disc has moved more anteriorly and medial than stage 2. Got it? Because in stage 1, they are very close, right? That's why there is inconsistent click. So it is sometime it is clicking, sometime it is not clicking. It is so easy for condyle to jump off the posterior side of the condyle. Okay, so here in stage 2, the condyle and the disc are so near, as the person will start opening the mouth, there will be click present early on opening. So once the person starts opening the mouth, the distance is so near between the condyle and the disc, there will be click early on opening because it will directly jump off from this posterior portion of the disc, right? Click will be early on opening and late on closing. Because why late? Because the condyle is here, sitting here, and has to travel this much distance, and the click will come once it will come off this bump, right? Now here in stage 3, click will be present later on opening, because this condyle will translate from here to here, the distance, right? The mouth is opened now, few millimeters is already opened because condyle has traveled from here to here, isn't it? Condyle will reach here in stage 3 little bit later compared to stage 2. That's why click will be later while opening and earlier while closing. Did you guys get it? What did I say just now? This is how I understood, guys. Okay, rather than mugging up, I thought in stage 1, the disc is too close. Stage 2, disc is slightly more anterior. Stage 3, the disc has moved slightly further anterior, so that I could correlate this. Click early, late. I don't know if this is the actual thing or not. It helped me to remember. That's it. Stage 3. Stage 4, this is the most painful stage. Remember, stage 3 is the most painful. Stage 1, no or mild pain. You can say inconsistent pain, moving to consistent pain. Then third is the most painful stage. Stage 4 is click is rare. Disc no longer relocates. Same thing, right? This is condyle. Now disc has reached over here. Too far. I'm exaggerating compared to these pictures. So no clicking, because condyle is not relocating at all. Condyle has to sit in the center to relocate, right? No click, no pain. Stage 4. So no pain could be stage 1 or stage 4. They will confuse with these terms. Patient came to you with clicking while one click while opening, one click while closing. So you will be stuck with stage 2 and 3. And the patient is complaining of click early on opening, late on closing. They will give this particular term. Then you should be differentiating, is it stage 2 or 3? If you mug up, chances are you'll forget. But if you remember this in this way, I don't think you'll forget. Okay. Okay, moving to the next slide. Okay, you must have seen this term trismus and bruxism. Trismus is muscle spasm. Which muscle spasm? Any of those muscles which you have read. Tim could be anything, right? So joint inflammation, trauma. Bruxism means teeth grinding, clenching. Usually people do whenever they are sleeping. Okay. So jaw opening in trismus is severely limited because of muscle spasm, joint inflammation, trauma. Bruxism, jaw opening is usually normal. There could be tightness. Pain in trismus often acute and associated with opening. Bruxism, they will have chronic pain, headaches, right? Trismus will be related to the acute pain, muscle spasm, joint inflammation, trauma. TMJ involvement could be possible secondarily. Here, bruxism often secondary to muscle overuse because of grinding, clenching. Now, in acute phase of temporomandibular joint pain, okay, so price MEM, protection, rest, icing, compression, elevation, manual therapy, early motion, medication. This is the approach. This is from Dutton, guys, okay? All the content, most of the content are from Maggie and Dutton. Now, resting jaw position, again, we are talking about it again, and if anything is repeating means that is important, guys, okay? So resting position of jaw is mouth slightly open, lips together, teeth not in contact, okay? Restrict movement to pain-free range to protect inflamed structure. This resting position protects inflamed structures. Gentle, frequent, active exercises stimulates mechanoreceptors and improve blood flow. There is one exercise called Rocabado 6x6 protocol. 6 exercises, 6 repetitions, 6 times per day. You can refer Dutton. This is a small paragraph. One paragraph. It will hardly take 5 minutes for you to read about it. Okay. The stage, what are the 6 exercises? First is tongue rest position and nasal breathing. Tip of the tongue on the roof of mouth behind front teeth. Breathe through nose using diaphragm only. So this exercise protocol is given to someone who is having TMJ problem. This is the first exercise. Second, controlled opening. Open mouth gently while maintaining tongue position. Can use cork between teeth for 2 minutes. That is controlled opening. Third, rhythmic stabilization. Apply manual resistance with hands on chin while opening, closing, and side deviation, kind of isometric, right? Apply manual resistance. The first one is it's all about the positioning of the tongue and breathing. Next is opening, gentle opening. Once they open the mouth, isometric, right? Fourth is cervical exercises. Release cervical flexions, hand behind neck, craniovertebral flexion. These are cervical exercises. Fifth is longitudinal neck extension. Glide head backward, upward. Shoulder retraction. Pull shoulder back, down, squeeze shoulder blades together for postural correction. Goal is strengthen jaw muscles, reduce spasm, improve coordination, correct posture. If this could be the scientist's name, he must have discovered this Rocabado 6x6 protocol. Now, what are the electrotherapeutic modalities? Yes, Ishan.
Sir, this position of the tongue, it has to be maintained only till step 2 or throughout the 6 steps?
No, these are the different steps. These are the different exercises. right? This is the first, this is second, third, fourth, fifth, sixth. Different steps. Read it, open Dutton, Ishan, okay? It will hardly take 5 minutes to read the paragraph of
Okay, sir.
Next is therapeutic modalities. Now, moist pack. So, if it is acute muscle trismus and all, we will go with cold pack, isn't it? If it is chronic condition, we'll go with moist pack. Same thing. It is just how we treat other MSK condition. We'll be treating same with TMJ. It is also the joint. It is also the joint. It is moved by muscle. Same thing, right? So high voltage electrical stimulation reduces muscle spasm, edema, muscle re-education, improves circulation. Ultrasound, this is important. Since it is a superficial structure, we are using 3 megahertz, 0.75 to 1 watt per centimeter square. It relaxes tissues, increases blood flow, micro massage. Effect is there with ultrasound. Iontophoresis. I think iontophoresis, they removed it. As far as I remember, they are saying it is not that effective, but it is in the Dutton. That's why I included corticosteroid, salicylates. Now, exercises for muscles and range of motion. So, strengthen cervicothoracic and scapular stabilizers, stretch scalene, trapezius, pec minor, levator scapulae, suboccipitalis. This is all leading towards the forward head posture, isn't it? These are tight in forward head posture. Upper cross syndrome. Address restricted mouth opening by range of motion exercises, joint mobilization, control active range of motion. Address excessive mandibular motion by muscle re-education, isometric within desired opening range. Normal things. Home program. Now, what we will teach in home program? Limit jaw function, soft foods, avoid wide yawning, chewing gum, perform the 6x6 protocol, habit modification and stress management, sleeping position, supine with cervical support. We will ask patient to avoid prone positioning. Okay, which glide would you give to improve mouth opening, guys? Come on.
Anterior.
Anterior.
Inferior, anterior,
So antero-inferior.
antero-inferior. I hope all of you are thinking at least. Those who are not talking. Okay? Everyone, you guys thought of your answer? Which glide will improve mouth opening? Try opening your mouth. Which glide will you give? All of us are physiotherapists, right? Think. Opening the mouth. Which glide? Anterior glide. Okay? So anterior glide indications: reduced mouth opening, disc displacement with reduction. So anterior glide improves mouth opening and protrusion. It go with the basic, guys, right? This is the disc, condyle, this is the lower chamber, right? So the condyle was gliding anteriorly to open the mouth. That's what we read. Okay, if there's a reduced mouth opening, what glide will we give? We will give anterior glide. Okay, technique: patient opens mouth slightly, therapist applies forward or anterior glide to mandibular condyle. So remember the first basic, right? That's what we read, I think, in the first, third, fourth slide, right? So it is anterior glide to open the mouth. There is distraction or inferior glide. Now, why would we give? If to increase overall joint space, reduce pain, capsular tightness, That is, that's why we use distraction, right, while mobilizing joint, any joint, to increase joint space. It reduces pain, and it helps with capsular tightness as well. Patient slightly opens mouth. Therapist places thumb or fingers intraorally on molar or anterior teeth. Apply gentle downward and inferior traction to the mandible. Indication: hypomobility, closed lock, capsular restrictions. These concepts are enough, guys. Okay, in TMJ, and guys, I must read a lot from Saunders, maybe many concepts. Yes, Razvi.
Sir, 2 to 3 slides back, you asked for closing the mouth. Which glide you give? So is it posterior, right? That's posterior.
To close the mouth. To close the
Yes.
mouth, it is posterior. To open the mouth, it is anterior.
Anterior.
Yes.
Thank you.
Yeah. Now,
And also for ultrasound, we don't give thermal effect, right?
thermal effect, again, we're sticking to the same principle. Okay. If any joint, if any joint is inflamed, we are not adding heat at that point.
Yes.
Right. We are keeping duty cycle less, maybe 20-40%, and keeping intensity lesser than 1 watt per centimeter square, because higher than that will produce heat, which will further aggravate the condition. That is the main thing. If you remember this thing, then whatever they will ask, you'll able to answer.
Okay, sir. Thank you. Yes. Thank you.
Okay. Now next is vestibular disorders and rehabilitation. Everyone has read, guys, about BBBV and all. I hope most of you, right? So help me, guys. Okay. Now let's understand about vestibular system, peripheral and central, right? What is peripheral vestibular system? What is there? Now, peripheral vestibular system helps us to keep vision clear during head movement by stabilizing our eyes. Maintain balance and posture, especially when head moves, and it sense head position and movement in spatial orientation. Not that important, just now these things are important. Semicircular canals. Okay, so there are 3 semicircular canals in each ear. Horizontal canal, we call it as lateral canal as well. Anterior, superior, AS, I remember as AS. Posterior, inferior, IP, iPhone, inferior, posterior. So inferior canal is also known as posterior canal. AS, anterior canal, is also known as superior canal. Horizontal canal is also known as lateral canal. We should know it. If you have remembered only anterior canal, if this is superior, gone. You don't know superior is which one then, anterior or posterior. So these canals are placed at right angle, 90 degrees to each other, like the corners of cube, to detect motions in all direction. Okay, here we can see in picture horizontal canal. This is the horizontal, posterior canal, superior canal. AS, this is anterior canal, right? Posterior is I, inferior canal. So these canals, okay. Each canal on one side of head works together with a matching canal on the opposite side. So basically, right side canal and left side canal, they are working together, okay, in coplanar pair. So right horizontal canal is working with the left ear, right anterior, left posterior, right posterior, left anterior. That's how they are working. So these are the canals, ampulla, inside ampulla there is cupula. This is A, ampulla is bigger. Inside ampulla there is cupula. The cupula of ampulla, see, is flexible. So this is cupula, inhibition, excitation. There are small cilias. These are cilia, right, which will detect motion, movement of fluid. Sterocelia, kinocilia, hair cell. No need to remember, guys, just basic idea. Now structure and function. The canals, okay, the canals are filled with a fluid called endolymph. Canal should have some fluid, right? As the name says, canal. Canal has water. So here, canals have fluid. It is called endolymph. When you move your head, the endolymph moves inside the canal, right? At one end of each canal is swollen part called ampulla, which contains cupula, a jelly-like structure, crista ampullaris, the sensory area within the cell. So this is canal, and the canal is swollen, right? Swollen. This is the swollen part of canal, and this it is called ampulla. It looks like A, and ampulla has, remember the picture, guys, okay, cupula inside it, right? And we have seen what is cupula. This is the cupula, right? The whole structure is cupula, which is inside the ampulla, having all this cilia, hair cell. These are the sensory structures, right? So each hair cell has tiny projections, sterocelia and kinocilium. This is too deep, guys, no need. Okay, so just know canals have the swollen part called ampulla. Ampulla has cupula inside it. What is push and pull mechanism? When the head turns to one side, the canal on that side is excited. The canal on opposite side is inhibited. This helps brain detect direction and speed of rotation. Simple, okay? When the head is turned to right side, canal on the right side gets excited and canal on the left side gets inhibited. So our brain will come to know that, okay, the head has turned towards the right, and also the speed will be detected by all those cilia which are inside cupula. That was about canal. Now there is something known as otolith organs, cortical and saccule. Now these detect linear straight line acceleration and head tilt. Cortical responds to horizontal movement, example, moving forward or sideways. Okay, cortical. This looks like magnet, right? Cortical, North Pole, South Pole wala, right? So magnet, how magnet attracts another magnet? In a straight line, right? So vertical responds to horizontal movement, moving forward, moving sideways, right? Guys, this is how if you guys tell me how it is the shape of magnet, this is what I read in physics, right? So if we keep two magnets like this, they will either repel or attract in the same direction, right? Moving forward or sideways. So vertical will detect horizontal movements, moving forward or sideways. Sequel responds to vertical movements, going up in elevator will be detected by sequel. Now inside them are hair cells embedded in gelatinous layer, just like cupula. On the top of this layer are tiny calcium carbonate crystals called otoconia. Okay, so the otolith organs have calcium carbonate crystals called otoconia, also known as otoliths. Liths, stone, right? Choleolisthesis, THESS. What is that? Stone, calcium carbonate, right? The weight of otoconia makes the hair cell response to gravity and movement, sending signal about position and acceleration to the brain. Again, weight of otoconia, weight of calcium carbonate crystals makes the hair cell respond to gravity and movement, sending signal about the position and acceleration to the brain. Basic anatomy and physiology, guys. Otoconia. Okay. See, otoconia are calcium carbonate crystals that are embedded in a gelatinous matrix which provides an inertial mass. Linear acceleration shifts the gelatinous matrix and excites or innervates vestibular efferents depending on the direction in which stereocilia are deflected. These are calcium carbonate crystals, gelatinous matrix, hair cells, macula. Again, summarizing once again, semicircular canals detect angular or rotational movement. Vertical U looks like magnet, it detects linear acceleration in horizontal plane. Sequel detects linear acceleration in vertical plane. Vertically is a big letter, right? Sequel. So semicircular canal detects turning head, left right, rotational, left right, nodding, tilting will be detected by semicircular canals. Vertical, moving forward and backward. That information would be sent to central nervous system by vertical. Sequel, moving up, down or head tilting will be sensed by sequel and would be sent to central nervous system. We'll talk about central nervous system as well very briefly, no need to remember anything. Okay, after peripheral vestibular system, which cranial nerve, guys? Vestibular.
8.
After peripheral vestibular system, in the inner ear detects head movement, the central vestibular system located in the brainstem and brain processes the information and coordinates balance, eye movement and posture. So these are the structures: vestibular nuclei, what cerebellum does, we know it, what does the thalamus, vestibular cortex, reticular formation. These are the structures which integrates information from the peripheral vestibular system, processes it, then responds accordingly, right? Through
Sir,
different.
this is only the vestibular spinal reflex.
Vestibulospinal reflex is not there. Vestibulocentral reflex is there, right? So Spinal reflex. If you say spinal reflex, let's say micturition process, right? S2, S3, S4. If it has to mediate through spinal, that reflex arc doesn't reaches to the brain. Yes, the pons is the has the micturition center in central nervous system. But if you are saying spinal reflex, so this is the afferent organ. It takes signal to the spine, and the response comes from spine only. And the person micturates if it is a spinal reflex. Cranial nerve, it directly goes to the brain. Correct me, guys.
Sir,
Okay.
but like on head movement to control the posture, like that also, like there's a reflex which is connected to the vestibular system, like to balance out or like to prevent ourselves from falling.
Mm-hmm.
Like if suddenly like our head is tilted or something and we feel like we're falling, suddenly our body will get tight and we'll try to straighten ourselves. So something like that is it's like the vestibular spinal reflex, like contraction of the postural muscle with the movement of the head. Like that thing is also there.
That is there. But is that the proper vestibular reflex you're talking? That
There are two,
reflex
like
is
one
there.
is vestibulo-ocular reflex and one is vestibulo-spinal reflex.
Okay, if you're talking about vestibulospinal reflex, yes, it spinal reflexes are very instant. Central reflexes takes a little bit of time, right? But all spinal reflex, they happen very fast. It is there. You're talking about those strategies, right? If
Yes,
someone
sir.
pushes, we use ankle strategy, hip strategies, and all.
No, that is like a balancing sort of thing. Like that comes under
Mm-hmm.
that balance thing. But this I'm telling the muscle contraction in response to head movement, which is triggered by the vestibular system.
Triggered by the vestibular system.
Like, sir, like when that endolymph, when all those things happen, like when they hit those hair cells and all, whenever that excitation thing happens, so like
Mm-hmm.
that eighth cranial nerve will carry the signal to the brain. And then
Directly to
after
the
that,
brain.
like,
It
yes, so
doesn't
it will.
it doesn't crosses it doesn't need to go through the spinal cord, I guess,
Correct.
because
So
it
that
is
is
the
for
cranial nerve.
vestibulo-ocular reflex. That is for vestibulo-ocular reflex. But like the for posture correction, like those muscles are always connected through the spine only. Like all our
Yes,
major
yes,
postural muscles. So
correct.
that
Yes,
vestibulo-spinal reflex I was asking.
vestibulospinal reflex. Yes, then there's no need of center nervous system. I mean, brain to come in action. That is very
Right,
fast.
right.
Yeah, I agree. I agree. Can anyone has any input in it, guys? My neuro is very not that good. Okay. Okay, we're talking about vestibulo-ocular reflex now, VOR. Okay, let's see. Now, vestibulo-ocular reflex helps to keep vision stable while your head moves by producing eye movements in the direction opposite to head movement. It allows you to see clearly when turning, nodding, or moving quickly. What is the main function of VOR? When the head moves in one direction, eye moves equally in the opposite direction. You look at the mirror, open the front camera, you look straight in your camera, turn your head towards the right, your eyeballs will move towards the left. That is vestibulo-ocular reflex. Okay, this keeps the image steady on the fovea. It is the part, right? It's the central part of retina responsible for sharp vision. Example, if you turn your head to the right, yeah, your eyes automatically move to the left. The visual target stays clear. This is vestibulo-ocular reflex. Okay. Table is there. Symptoms and possible causes. Vertigo. Okay. Vertigo patient will, if they ask you in exam, patient complains of blah 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 and vertigo, then you should think of, okay, it could be BPPV, it could be UVH, it could be unilateral central lesion affecting vestibular nuclei. It cannot be orthostatic hypotension. It cannot be some other thing, upper brainstem or vertebral cortex lesion. Okay, so vertigo can happen with BPPV or unilateral vestibular hypofunction, unilateral central lesion affecting vestibular nuclei. Lightheadedness. What could be the possible cause of lightheadedness? Orthostatic hypotension, hypoglycemia, anxiety, panic disorder. So how would you, okay, a patient is complaining of lightheadedness and patient is sweating profusely. What is suffering from, guys? Select from these four options. 1, 2, 3, 4. Patient is having lightheadedness and sweating. Which condition is he having from it? From this?
Anxiety.
Hypoglycemia.
Sir, panic attack.
Hypoglycemia. I guess hypoglycemia, guys. You guys have read it. In hypoglycemia, there is perspiration. Or is perspiration is in hyperglycemia? Speak up, guys. Come on, help me. I haven't revised this since many days, I guess.
Dry is hyperglycemia, perfusion is hypoglycemia.
Hypoglycemia, right?
Yes.
So perspiration will be there in hypoglycemia. Always remember, in hyperglycemia, the person won't be sweating. But in hypoglycemia, person will be sweating. Okay. Symptom. Next is disequilibrium. BVH, chronic unilateral vestibular hypofunction, lower extremity somatosensory loss, upper brainstem or vestibular cortex lesion, cerebellar and motor pathway lesions will result to disequilibrium. Okay, next concept is nystagmus. So what is nystagmus? Nystagmus is an involuntary rhythmic movement of eyes. Involuntary rhythmic movement of eyes. It is the most important sign to identify vestibular lesions, either peripheral or central vestibular. Okay, it is one of the most important signs to identify vestibular lesions. Each nystagmus has two components. Now, we're talking about rhythmic movement of eyes, basically eyeball. Right? Now, each nystagmus has two components. Slow component caused by vestibular imbalance and fast component, corrective eye movement, bringing back eye to the center. This is eye. Okay. If the eyeball moves towards this side slowly, okay, then it will move very fast towards this side to bring this eyeball at the center. So moving to one side initially is the slow component, and the corrective eye movement, which brings back eyeball to the center, is the fast component. So the nystagmus has two components. The direction of nystagmus is named by the fast component. So let's say this is the right side, this is the left side. The eyeball is moving slowly towards the right and coming back quickly towards the left. If we see that, then we would call it as left nystagmus, because the fast component is towards the left side. Okay, example, left beating nystagmus. I drift slowly to the right, then quickly jog back to the left. We will call that as left beating nystagmus. Clear, guys? Next, mechanism of nystagmus in UVH, unilateral vestibular hypofunction. Name is clear? So we have vestibular system on the both side. This is the head. Here vestibular system on this side, vestibular system on another side. Now nystagmus happening in unilateral vestibular hypofunction, either on this side or other side. Okay. Now in left UVH, okay, what is SCC, guys?
Semicircular canal.
Semicircular canal.
Right. So left UVH, let's say this is left side unilateral vestibular hypofunction. Left side vestibular system is not functioning properly. Okay, it is functioning 20%. So hypofunction, right? So left side semicircular canal activity will be definitely less, right? If left UVH is there, left unilateral vestibular hypofunction is there, that means on the left side semicircular canal activity will be decreased, and compared to the left side, semicircular canal activity on the right side will be high compared to the left. Got it, guys? Clear till now? Hey, you guys are sending thumbs up, right? I'm not looking at the screen. So if there is a less signal coming from the left side compared to the right side, what brain thinks is head is moving towards the right. We read it. Okay, so head is, now the brain is perceiving as the head is rotating towards the right side because more signals are being received from the right side. Now eye slow phase. So the brain thinks head is moving towards the right. We just read, if head is moving towards the right side, where will your eyeball will move? Normally towards the
Left.
Opposite side.
left side. Eyes move towards the left. That is the slow phase, right? And the corrective is eye moving towards the back to the right side. So we will call it as right beating nystagmus because the correction happens in the faster speed, and we call nystagmus on the basis of fast component. Which side the fast component is happening? Fast component is happening towards the right side. So it is right beating nystagmus. So in exam they can ask you are checking the person with left ear injury or left-sided trauma. He had a hit on the left side. He came to you, right? And you checked. And upon checking which side nystagmus you will see. That is, if the person is having left UVH, hypofunction of the left side, we would notice right beating nystagmus. Clear? I'm not reading this. This is just opposite of the upper one. Next is head shaking induced nystagmus. Okay, It detects unilateral peripheral vestibular defects. Again, head shaking HSN test detects unilateral peripheral vestibular defect. Procedure: occlude vision, eyes closed, or they can use goggles. Flex head 30 degree. We're checking horizontal canal, that is the horizontal canal position. Flexing head 30 degree. Shake head horizontally for 20 cycles. Head is flexed 30 degree. Head is shaken horizontally for 20 cycles. Stop it. Ask patient to open eyes. Now see for nystagmus. This is the procedure. I'll send this. You can watch a small video, 2-3 minutes video on YouTube. The same thing is done over there. Okay. Now finding. After doing this, we can see no nystagmus. If there's no nystagmus, then that is normal vestibular function. If there is horizontal nystagmus, fast forward towards healthy air, that is, we can say there is UVH. No nystagmus, bilateral loss, both sides absent. Vertical nystagmus suggests central lesion. They can ask this. You did HSM and you noticed vertical nystagmus. What does it suggest? Suggests central lesion. You should know it, guys. Okay, just watch this video. Things will be more clear. Now, BPVV. Let me drink water, guys. Just take a break, guys. Drink water. Get up, stretch. Okay. Now, BPVV. Benign paroxysmal positional vertigo. BPVV is a peripheral vestibular disorder caused by displacement of otoconia, calcium carbonate crystals. Now they are displaced. We saw it, right? They were just lying on the top of that structure. From otolith organ, vertical or saccule, into one of the semicircular canals. Now, these calcium carbonate crystals, which were in the otolith organ, are displaced from there and they are inside semicircular canals. Most commonly, they are displaced to the posterior canal. These loose crystals move with head position changes, abnormally stimulating hair cells and creating a false sense of movement, that is vertigo. Now let's understand the mechanism behind it. Normally, otoconia helps detect linear acceleration and gravity. We read it. When they dislodge into a semicircular canal, especially in posterior SCC, they make canal overly sensitive to head position changes. This leads to brief episode of vertigo and position dependent nystagmus. So vertigo and nystagmus are key signs of BPPV. So what are the typical presentation? Patient often report brief intense vertigo lasting seconds to minutes. Very important, guys, because in exam they will give you condition. Okay, the person is experiencing vertigo 4 seconds to minute. If this line is there, think about BPPV as well, isn't it? Triggered by, now these words will be there. Patient is complaining of vertigo for some seconds to minute after looking up and down. They might say reaching a self. Person is complaining of vertigo a few seconds after rolling in bed. After tying shoes, that means bending forward. Moving from complaining of vertigo for a few seconds or few minutes while moving from sitting to supine. Think it is BPPV. All these words are important. They can frame question from these things. Now, associated features. Transient nystagmus will be there. Sometimes nausea, lightheadedness, or imbalance. No hearing loss or tinnitus. Tinnitus means, what is tinnitus, guys?
Ringing in the ear.
Ringing, yeah, in the ear. So Meniere's disease has hearing loss and tinnitus. So that's the typical presentation of BPPV. Now, positional tests for BPPV. First is disc Hallpike test for posterior or anterior canal. Just this test only tests these two canals, not the horizontal one. Okay? It detects posterior anterior canal. Procedure: patient sits on a plinth, head rotated 45 degree to the test ear. Make it easy, let's say right side. Okay, we want to test right side. Okay, the patient is sitting on the plinth, head is rotated towards the right side 45 degrees. Patient is quickly brought to supine with head extending 30 degree below horizontal and maintaining the 45 degree rotation. We are going to hold that position for 30 seconds and look at the eyes. For nystagmus, the person will complain of vertigo. This is the sign. Vertigo is the symptom. Right? So positive test, latency of 1 to 5 seconds before symptoms start. Transient vertigo with rotatory upbeating nystagmus. If you notice as a physiotherapist, what upbeating nystagmus, if you notice it, then you will say it is in the posterior canal. That calcium carbonate thing is in the posterior canal. If you notice upbeating, it is posterior. UP, up. P, posterior. If it is downbeating, then anterior canal is affected. You'll either see upbeating nystagmus or downbeating nystagmus. If you notice the faster component is towards the up, then it is posterior canal. If it is downbeating, then anterior canal is affected. Fatigable response, symptoms reduced with repetition. The ear turned downward is the tested ear. Yes, because rotated right? So if sign and symptoms are immediate, we will say cupulolithiasis, right? If sign and symptom disappears late, we'll call it as canalolithiasis, lithiasis. I forgot, guys. Why canal? Cupulo means, okay. If that means why sign and symptoms are coming faster means cupula has that, right? Those structures. Cupula has these structures which can sense very faster. So if the sign and symptoms are appearing here, that means these calcium carbonate crystals are very close to cupula and symptoms are coming very fast, right? These are in the, this cupula is under ampulla, right? What is ampulla? Ampulla is just the distension of canals. If these calcium crystals are far in canal, so after turning head to that side, we are just stimulating. These will come slowly towards cupula. Okay, so that's why sign and symptoms are slower. Got it, guys? I hope you're understanding something. Hello?
Yes.
Sir, we are sending thumbs up.
Oh, you guys are sending thumbs up. Okay, good. Yesterday I was talking, guys. I didn't realize that the internet was gone and all. I changed the slide. Like I was keep on talking. Then I realized someone sent me a message. You are not audible. Then I'm like, how come? Okay. We were here, right? Okay. This is the disc hall pike. Watch a video on YouTube. Disc hall pike test. Okay, you'll understand it better. Watch today only. I'll send this slide after the class. Go through it. Watch it. See, the patient was sitting on the plinth. This is the right side of the this right here. Therapist rotated the head towards the right side 45 degree. Then the person goes in supine position with 30-degree head extension, and the therapist is checking I, nystagmus, right? If it is upbeating, then it is pushed. The problem is in the posterior canal. If it is downbeating, then it is anterior canal. That's it. We are just it is a diagnostic test. We're using disc hall pike test to find out where the problem is. Done. Now what about horizontal canal? There is something known as modified side-lying disc hall pike test. So it is also a diagnostic test for posterior canal BPVV. Modified test for posterior only. Used instead of disc hall pike when patient cannot tolerate neck extension or supine lying. Okay, what are the steps? Patient sit on the edge of the plinth, same like disc hall pike. Head is turned 45 degree away from the side being tested. If you want to test the right side, you are turning head towards the left. Patient quickly lies down on the test side, right side, the ear towards bed is being tested. Clinician observes for nystagmus and vertigo for 30 seconds. Returns to sitting and repeat on the other side if needed. So if you want to test the left side, then turn head towards the right. And we are not doing neck extension because this is done to the patient who cannot tolerate neck extension. Now there's another test. Horizontal canal was remaining. Disc hall pike was for anterior and posterior. Modified was for just posterior. And for horizontal canal, there is test called supine roll test. Patient lies supine, head flexed 20 degree. How head flexion? If we keep pillow under patient's head is flexed, right? So patient lies in supine, head flexed 20 degree. Quickly rotate head 90 degree to one side and absorb. That means rotate either towards right or left. Okay. So here, see, as you can see in the picture, This is the 90-degree rotation. So return to center, repeat on opposite side. So positive test, horizontal nystagmus, geotropic or agiotropic. The more symptomatic side indicates affected ear. So geotropic is downwards. Geo means soil, right? Soil, geology, I don't know, soil, whatever. Okay, so geotropic means down. Roots, where are the roots of the tree? Down, right? So geotropic means down. Where are the canals? Down, right? Below the surface, below the walking surface. Canals are deeper than the road or whatever, right? Or the surface where we walk. So canalolisthesis, if you notice, downbeating nystagmus, that is canalolisthesis. If you notice upbeating nystagmus, then it is cupulolisthesis. Guys, watch a video on YouTube. It will be much clearer. Still confusion? We can talk. Okay, read as well. Read by yourself. The small thing you will come to know. So what are the contraindications to disc hall pike? So cervical spine instability, AA instabilities, subluxation, in RA, Down syndrome. Guys, did you guys read Down syndrome? We treat all Down syndrome patients as if they are having AA instability until some age. Then after, I don't know, few months, 15 months or something. Then after that, we do X-ray of the patient to confirm if the patient really has AA instability or subluxation. Until that, we treat all Down syndrome patients as if they are having instability. Okay, we don't do disc hall pike if the patient is having vertebral artery insufficiency, if there is a prolapsed intervertebral disc with radiculopathy, cervical myelopathy, previous cervical spine surgery. In these conditions, disc hall pike is contraindicated. So now we have diagnosed with these tests. Now, what is the treatment? Treatment is Epley's maneuver, that is also known as canalith reposition maneuver, CRM. Okay, Simon's maneuver for posterior canal, Lampard-Parvicue roll maneuver for horizontal canal, branded Daroff exercise or home habituation exercise. Okay, so treatment procedure CRM, same thing, BPVV due to canalolisthesis, posterior SCC canalithesis is most common, levatory maneuver for cupulolisthesis, posterior SCC, branded Daroff exercise, persistent or residual mild vertigo even after CRM is there, then we go with this exercise. For patient who may not tolerate CRM, we go with this exercise. Now coming one by one, what is the Epley's maneuver? Okay, based on the canalithesis theory, where free floating otoconia in the posterior semicircular canal causes abnormal endolymph flow and vertigo. Now, goal of this maneuver is to guide these otoconia back from posterior canal into vertical, where they can be reabsorbed. Steps. Now, okay, we'll take an example, right side, okay. Patient sits upright with head turned towards the right. Remember disc hall pike, guys. Okay, Now quickly lie back with the head extended around, remember 30 degree only. Okay, head extension 30 degree like this whole pike. We are maintaining this 45 degree right turn position. This places right posterior canal in the place of movement. Wait for 30 to 60 seconds or until vertigo or nystagmus stops. Now without lifting the head, rotate it to 90 degree. Till here is disc hall pike. That is the test. We come to know that there is something in now posterior canal on the right side. Right. Now please maneuver from that position, turn head towards the other side, rotate to the left side, and again hold it for 30 to 60 seconds. Roll the body on the left side so the nose points downward, facing floor, and hold it for 30 to 60 seconds. Slowly sit up, keeping chin slightly down. What is the outcome? Often symptom improves after 1 to 3 sessions. Okay. Post-treatment care, earlier protocols suggest sleeping semi-upright or avoiding the affected side for few nights, but no strong evidence. Yesterday we read, right? Pyramid of evidence. So it might fall somewhere here. Having low evidence. Next is liberatory or Simon's maneuver. Now again, it is also based on cupulolisthesis theory, where otoconia are attached to cupula, making it abnormally sensitive to gravity. Goal is to dislodge otoconia from cupula. Here, where was otoconia? In canal. Okay, this posterior canal will swell up to form ampulla, and inside ampulla there is cupula. Now, liberatory or Simon's maneuver is used where otoconia is attached to cupula, making it abnormally sensitive to gravity. Now, to dislodge otoconia from cupula, moves them into vestibule. That's our target. The procedure, again, we're keeping reference to the right side. Patient sits with head turn 45 degree to left. Okay, right side is affected. We are turning the patient's head to the left. Now quickly move on right side lying, keeping head turned upward. Very simple procedure. If you do it on yourself, you'll remember. Just remember that you have to look up first. Okay. Hold for 30 seconds. Liberate. Liberation. Nirvana. Think. Where did the soul goes? If it gets liberated, up. So first thing is looking up. Rotate the head away from the affected side, keeping the 45 degree. Patient should lie on a couch in such a way that he should be looking up for 30 seconds. Then rapidly move to another side, opposite side, where his face or the patient's face will be facing downward. Then also hold it for 30 seconds. Done. That is Simon's maneuver. Okay. Slowly return to sitting. Can be more intense for patient, but it is effective maneuver. That's why we are reading about it. Next is branded tear-off exercise, home habituation program. The purpose of it is, it was originally designed to habituate central nervous system to the provoking positions. It may also help dislodge debris from cupula or canal through repeated head movements. Basically, we are dislodging from canal and cupula and we are throwing it to its original place. Procedure, keeping the right side. From sitting, quickly move into right side lying with head looking 45 degrees to the left. Hold until vertigo stops, plus 30 seconds. Return to sitting. Repeat on left side. Frequency 5 to 10 repetitions, 3 times per day until no vertigo for 2 consecutive days. So this is home program. This is how we are prescribing. We are asking them to do 3 times per day until no vertigo for 2 consecutive days. If vertigo, nausea is severe, reduce to 3 repetition 3 times per day from 5 to 10 repetitions. But they still needs to do 3 times per day. Patient education. Movements may provoke vertigo initially. That is expected. You have to teach them. Some residual imbalances or nausea may persist temporarily. Continue exercises consistently for best results. So these are the patient education which you are going to tell patient. Home habituation program. So CRM, this is what we did. Right, this is the example. It was here near to ampulla. So after rotating head, it reached here. We turned head from here. It went up. It is here, right? It is original to the place where it was. It's not in the canal anymore, not in the ampulla anymore. This is from Suleiman, guys, okay? Another procedure, we have already discussed about it. You want to read it, you can read it. Now, other vestibular rehabilitation, UVH, unilateral vestibular hypofunction. We read about it. If right side is hypofunction, we will see nystagmus on the which side, guys? If right UVH is there, nystagmus will be on fast beating. Nystagmus will be on which side?
Left.
Left, right? General goals. If there is UVH, our goal is to improve gauge stability during head movement, reduce motion sensitivity, improve static and dynamic postural stability, achieve independence in home exercise program, including walking. Recover typically average 6 to 8 weeks. UVH. Frequent encouragement and goal reinforcement improves adherence. Now, what are the exercises for UVH? Gait stability exercises. What does it do? It improves VOR and visual stability during head motion by reducing retinal slips. Exercise. Okay, here basically, see, picture A, C, and E. This is one paradigm, right? What we are doing is, we are asking patient to focus on the target, okay, which is a near target. Then we are asking patient to rotate head to either side, focusing on the target. Here the patient is rotating head towards the right, and here the patient is rotating head towards the left, focusing on the target. That is the first one. Second one, B, D, and F. Here we are moving head to one side and the target to another side. Here the patient still focuses on the target, but head is also moving, the target is also moving, right? The second F picture, head is rotating towards the left side and the target is moved towards the right side. Got it, guys? So this is what it means. So progression, add visual distractions. So these are the distractors. Change distance of the target, increase head speed, perform while standing or walking. Assessment is done by computerized. Oh, okay, wait. Some people had to join. Ask me. So assessment is by computerized DVA, dynamic visual acuity. So this can test improvements. Just read it. It is easy, right? In these three, we're keeping the target still. Target is not moving, only head is moving, and after that, not only head but also target is moving in opposite direction. Next is postural stability exercises. Now, what is the purpose or aim of this exercise? Is to improve balance using vestibular, visual, and somatosensory systems. Guidelines: begin with safe exercises, gradually increase challenges. Include head movements during balance exercises, as patients tend to restrict head motion. Basically, start with simple exercises and make it more complex. Habituation exercises, which is motion sensitivity. It reduces dizziness from repeated exposure to provoking movements. Identify provoking movements via positional testing. Maintain position for 30 seconds or until symptoms abate. Perform 3 to 5 repetitions 2 to 3 times per day. Progress exercises if symptoms improve. Change if no improvement after 2 weeks. Use an activity diary to monitor response. Note, not all UVH patients need habituation. Individualized selection is essential. So all this process, it is given in Maggie, guys, or you can watch one video, habituation exercises for UVH patient, maybe hardly 5 minutes video. Same thing will be explained in the video. It will be easy for you to remember what is habituation exercise. No need to mug up, just watch a video, understand it, done. Now, in bilateral vestibular hypofunction, what is the goal of rehabilitation in it? Is to improve gauge stability and reduce complaints. Now, improve static and dynamic balance. In VVH, BVH, so bilateral vestibular is hypofunctioning. There will be a lot of issue with balance. Okay, so our aim is to improve static and dynamic balance. Achieve independence in HEP, including walking. Enhance decision making for daily activities and fall prevention. That is our aim of rehabilitation in person who is having BVH. Management would be same gauge stability exercises, postural stability exercises, focusing on vision and somatosensation. Vestibular is gone. There are just 3 systems, right, working on balance. So work on vision and somatosensation. Begin walking programs, progressing to varied surfaces, grass, sand, malls. Recovery can take up to 2 years. Ongoing daily activity is crucial. So BVH recovery can take up to 2 years. Pool exercises, Tai Chi are helpful for safe balance training. Okay, so they can ask which exercises are safe in BVH. So look for pool exercises, Tai Chi. Okay, habituation exercises is not effective in VVH. Important point, right? Limitations: patients may have permanent activity restrictions, night walking, driving, sports. Assistive devices may be necessary. So this is the table, which I'm not going to read line by line. You guys have to read it. So I'll just read the first one. If we perform a Romberg test in a patient who is having BPVV, it will come negative. But it will come positive if the person is having UVH and BVH and they should be in acute stage. Then it will turn to be positive. But in chronic stage, Romberg test will come negative in both UVH and BVH. In central lesion, Romberg test is often negative. There's no any technique to remember it. Read it, understand it, correlate in your how you want to correlate. That's it. Okay, read this table. Guys, are you with me? Okay. Now you guys must have received one table on WhatsApp. Have you?
Yes.
Okay. So this table is very important. Now you can see BPVV, UVL, VVL, and this is central lesion. Okay. Now, if you see vertigo and dizziness, so there is vertigo and dizziness, transient vertigo and dizziness in BPVV. Okay, which is positional vertigo and lasting for 2 minutes. So if you see the third, see, there's no vertigo in VVL, right? So it helps you to understand, differentiate between BVL, UVL, and BPVV. Now, if you see in a question saying that the person is having vertigo, at least you can eliminate BVL from option, right? So read this table. Okay, so nausea, other symptoms, nausea, vomiting, and imbalances, lightheadedness may or may not be present in BPVV, right? Imbalance is there, oscillopsia, again nausea, poor gauge stabilization may or may not be there. If you see BVL, see the fall risk plus, because bilateral vestibular loss. So both side vestibular system are not working. You'll get in question you'll get things like person is complaining of frequent falls, or in question they might say a person has come across, or there's 10 incidents of fall in last 2 weeks. Then you can think of BVL among all these 4 conditions, right? So see, no nystagmus in BVL. In UVL, nystagmus is there in acute phase only. Read this table. This table will help you to differentiate these conditions: BPVV, UVL, BVL, and central lesion. If you know this table by heart, you'll nicely differentiate among these, and you'll able to solve the question. I'm not going to go in details of that table. It is easy one. You guys have to read. Small, you should know about Meniere's disease. What is it? It is a disorder of inner ear characterized by episodic vertigo, low frequency hearing loss, tinnitus, right? And sense of earfulness. Tinnitus, nowhere there was tinnitus, right? So vertigo is there. If you see vertigo and tinnitus, then it is Meniere's disease. If you just see vertigo, tinnitus is not there, you can eliminate Meniere's disease, right? Vertigo episodes can last several hours and symptoms gradually increase in severity over time. What is the pathophysiology behind it? Likely due to endolymphatic. No need, guys. No need to study so in this detail. Coming to the last slide, that is contraindication to vestibular rehabilitation, physiotherapy, right? Contraindications. So unstable vestibular disorders, active Meniere's disease, we're not going to perform vestibular rehabilitation. Uncontrolled migraine associated vertigo, perilymphatic fistula, unrepaired superior semicircular canal dehiscence, acute or concurring vestibular symptoms, sudden hearing loss, severe or painful earfulness pressure, severe tinnitus in one or both ears, post-surgical precautions, fluid discharge from ear or nose, that could be CSF leakage, post-operative instability or hearing issues. We're not going to perform vestibular rehabilitation in these patients. What are musculoskeletal limitations? Acute neck injuries may prevent safe performance of CRM, certain gauge stability exercises, head movement required for testing or therapy. That's it, guys. Now, tomorrow we'll have cardio revision.